Yeah, I'm going to transition it to our last talk before lunch. Dr. Gitta Lubke is going to talk to us about the science and research program here at the PFIC Network. So take it away.
Yeah, thanks, Emily. I don't know whether the mic is working or not. So yeah, my background is in what's called quantitative psychology, and what that means is basically developing tests for all kinds of things that you want to measure in human beings. Think behaviors like sleep or mental or physical health, but also like all kinds of other things. Educational testing is also part of that. So yeah, there's a whole science to that. And when PFIC Network decided to go ahead and really design a registry, I'm like, yeah, oh, cool, we can totally do that. Got really excited. And so 2 years ago, at the PFIC conference in Philadelphia, we officially launched the registry. This survey includes, of course, diagnosis, symptoms, medications, surgeries, but also itch, sleep quality, general health, family quality of life. I don't know, is this better? Okay, perfect, thank you. So when you first enroll in the registry, it takes about 30 minutes to read the consent. The consent outlines basically the rights of the patients, how your data are being dealt with. You can opt in or opt out, whether you want to get contacted when there are research opportunities, those types of things. And then to fill out the survey altogether. So the first time you enroll, it takes about 30 minutes. And now our current number of participants is 135. We collect data every 6 months. So here's how that works. No matter when you enroll, you can enroll whenever you want. When you enroll for the first time, 6 months later, you get an automatic invitation to fill out the follow-up survey. And then again, so say you enroll now, then in half a year, you're going to get the first follow-up invitation. In a year, you're going to get the second invitation, and so forth. The follow-up survey only takes about 10 minutes to fill out because you don't have to go through the consent again. And some of the follow-up questions are just a little bit shorter. So now the big question here is, why are we collecting data every 6 months? Why do we bother you guys to kind of like, oh, fill this out, please, again? Well, multiple waves of data permit how to really like follow a patient, how they fare over time, right? So it's basically a storyline that you create by filling out these questionnaires twice a year. So as an illustration, like several participants had liver transplant after they enrolled. So now we have data how it went before, but also we have data how it went after, right? So we can see the effect of liver transplant on itch, sleep, family quality of life, and general health, those types of things. So now in the registry, we use these what's called PROMIS scales. That's an acronym that stands for Patient-Reported Outcomes Measurement Information Service or something like that. Anyways, it's a group of people who are like me, they're nerds. They develop scales and make sure that these scales have high quality and actually measure what they're supposed to measure. And what they also do, they provide, I don't know, oh, nope, not a good idea. I don't know whether I have a laser. But anyways, as you can see there, what the PROMIS team is also providing is an interpretation of your test score, right? So you answer a question, every question gets scored, you have a total score on that test, and then you basically get this interpretation of your test score. So one of the patients with before and after data on liver transplant had an itch score really severe before liver transplant, and then after liver transplant, that itch was gone. So in that sense, that surgery was a success. And this is the sleep quality scale. PROMIS scales very often have, like at 50, that's the US population mean, you know. Here it went from 82 to here. So it's within normal limits, but it's not quite, it's still a little bit worse than on average in the US population. And the next one is about global health. And again, you can see it goes from really bad, but the score now is here. So it's not quite good. And then after liver transplant, it's the global health measure is in the fair range. So longitudinal data, it's not only like liver transplants that you might want to look at, but there are all kinds of different aspects of PFIC that change over time, right? So for instance, changes in weight or diarrhea, to look at effects of nutrition supplements, whatever. Those types of questions can be addressed with these like longitudinal data because you can look at how it goes over time, right? And then what's important when it's not only that you want to look at one individual, right? If you have more data, you can start looking at the similarities and the differences between these individual storylines, right? And that is, of course, like every patient is unique, but there are similarities that you might want to know about. So I think these data are important for families to know. There also, these trends are important for advocacy, and of course, they're important for research to learn more about PFIC. As I said, the follow-up questions only take 10 minutes to answer, so that's 20 minutes per year. We have also like a little bit of a financial incentive. There's a raffle twice a year. The next raffle is coming up coming months, and everybody who enrolled or filled out follow-up data in the last 6 months is going to be included in that raffle. It's a patient registry, and it's really also patient-driven in the sense that we listen to what people tell us, right? So in Project Impact, we're going to have the round table after lunch here. The discussions were treatment-related, right? The Project Impact is about treatment. And they reveals the importance of acknowledging financial burden. So that really came up multiple times during the discussions. So we decided to launch an add-on to the registry with 7 financial burden questions. And that add-on just got approved by our IRB, so we are good to go on that front to include that in the registry. The questions that we chose, those 7 questions, are the same as have been used for years in the National Service of Children's Health. That's a U.S. Yearly survey. The nice thing about that survey is that the data are publicly available. So when we start collecting these data, we will be able to compare that to U.S. data. And not only US data, I know there are definitely like a lot of people from Canada here and other countries. So similar data are very often collected in other countries as well. So I've already like followed up a little bit with Canada and EU, but I'm pretty sure very similar questions are being collected worldwide. So how does this look? So I hope you can read that, but this is how this will get integrated in the registry. The first question is about out-of-pocket costs. And so don't be afraid, you don't have to dig into your finances to be able to answer these questions, right? The only thing that we want to know here is your best ballpark estimates. Right? Was it $0? Was it 1 to 250? Was it 250 to 500, and so forth? Or was it more than $5,000 a year? Right? And then the second question is, did your family have problems paying for any medical or healthcare bills? That's a yes or no answer that we want to have here. And then there are 3 questions about how PFIC affected your job life as a parent, right? Did you have to take a leave of absence? Did you cut down on hours that you were working? Or did you keep your current job to be able to keep the insurance, right? So all these questions, we didn't make them up. These are exactly the same questions that are being asked in the national survey. And the last 2 are about how many hours in an average week you're spending on childcare that's illness related, and organizing care, right? Driving to the hospital, et cetera, et cetera. Okay, so those are the questions. This add-on will launch in May, and everybody who is currently enrolled will get a personal email and text invite to complete these 7 questions. And for future participants in the registry, those patients who are going to enroll in May or later, they will just get those questions as part of the registry. Now, these questions are not required. If you don't want to answer those questions, you can definitely skip them. But of course, the more data, the better, right? We can, if we have enough data, we can look at the burden associated with specific treatments. We can look at, are the costs higher when patients are younger? All kinds of questions in that direction. The more data you have, the more you can slice the data any which way. Last point here, the registry as a patient registry it's possible for researchers to apply to get access to the de-identified data. De-identified means we scrap names, emails, phone numbers, addresses, everything personal that could trace the data back to you, to the patient. So that's scrapped, so every participant in the registry just has a number. And then that's what de-identified means. And then the process for researchers to apply to get access to these de-identified data is they have to fill out a form that's on the PFIC Network registry webpage. They have to describe what type of data they want, what the purpose is, and then also an IRB-approved research plan, what they're basically planning on doing with the data. And then all applications will be reviewed by PFIC Networks. There's a procedure in place to get the review done in a timely fashion. There's also a possibility to reach patients who opted in to be informed about research opportunities. It's the same application process, again, filling out that form on the PFIC website. And if approved, PFIC Network then reaches out to patients who opted in to get informed about about research opportunities, and then patients can decide whether they want to contact the respective researcher and participate in the proposed study. Okay, so in sum, the registry has really grown quite a bit in 2 years. We have 135 participants, and more than 60% filled out wave 2, so their first wave of follow-up data. That percentage is a little bit lower for waves 3 and 4. I know from my experience it's quite common that you get this like dropout, but please don't drop out. Give us your data. We need all the follow-up data, even if everything's stable. That's important to know too, right? Yeah, 10 minutes. Please. Also, if you have any ideas of how to use the data or what type of data you want to see shared in summaries like online or whatever, let us know. We are very interested in knowing all these ideas, just like with the financial burden data, that's just like patients told us, this is important for us, and so we integrated that in the registry, and we can make these changes relatively fast. So that's a nice thing about a patient registry, I guess. So I've said that multiple times, but yeah, PFIC patients are the expert of what it means to live with PFIC, right? So share that experience and participate. Thanks.
Thanks, Gitta. So open for questions. I think, oh, here we go. I'm going to start and work my way across the room. Oh, go on, Ben.
That's great. Congratulations. It's very exciting. I enjoyed your request for queries and potential analyses. I think one thing that is a suggestion that might be helpful, and I don't know if it's possible, to post descriptive data of what you have. I think it's very hard for someone to come up with, well, without knowing what's in there. Right. I mean, we know the categories, but to get a sense of, we have X number with this, people with this problem. We have promise scores that range from this and descriptive statistics. I think that would be very helpful for the community.
Yeah, thank you.
Okay, apologies for my perimenopausal brain. I can't remember if I probably have signed up and done it, but I can't remember. Is there a way to check?
Yes.
Oh, great.
Comes to me.
Okay.
I'm just curious with the financial burden, if you are thinking of including information from more than 3 months past. So for us, our financial burden really began when her PFIC diagnosis came 6 years ago. Obviously, the registry is not that old. So we continue to have a financial burden. However, we've sort of learned to accommodate that, whereas 6 years ago, we experienced a much greater financial burden with this. So as that, those questions are coming out, will you be looking for information for longer than just the last 3 months?
Yeah, no, that's a really important question, of course. So when you enroll in the registry, we know the date of birth, basically how old your child is, right? The financial burden questions. The financial burden questions are very precise in the instructions. It's in the last 12 months, right? So that, because then we know what the financial burden is for your slightly older child, right? We have a lot of patients enrolled that are younger. So from those, we will then get the data of what the financial burden is when the patient is young, So the instructions, follow the instructions, they're pretty clear in the last 12 months or in an average week in the last year. Yeah? Okay.
Gitta, thank you very much. I think it's a really important initiative. We don't know what we don't know. And I think you can ask us structured questions, which is great, and do share that on the website so that we know what questions are being asked. But it's the questions that we don't know what are the correct questions to ask. I hope there's some free text in there for people to post what issues they're facing, and that's the only way we'll develop themes of problems that we're currently unaware of. So I think that's a really important feature. It really encourage people to put in other issues which we really haven't thought about properly.
Yeah. No, thanks, Richard. Yeah, that is definitely, there is a lot of like open-ended questions. Do you want to add anything, or do you have experienced any symptoms that haven't been listed? Those types of things. There's in multiple places in the registry, there's open-ended answers. Yes.
So gathering information is interesting for us as the professionals, but can you be specific about how you think this data will help families in the future?
Well, so when we, that's, again, it's a very interesting question. When we started Project Impact and started talking, really having these focus group discussions with patients and clinicians, it became a little bit more clear where the questions would be, So I think it's really the stimulus that we are getting from the patient community that is going to direct also what we are going to do with the data, or basically what the family want to happen,
Other questions, comments? Emily's got one. Far away from me as you can be. Oh, it's in the virtual chat. Oh. Can you post the link to the registry?
Yes, Emily, you can.
I mean, I guess I would, maybe, we have a couple minutes to lunch. I mean, I would maybe reiterate, a couple things. We'll see after lunch at the Impact Focus session. Paolo will introduce the kind of website that is coming out of our impact work that is kind of designed to capture more patient experience, right? And so I think that's going to be a really neat and exciting new opportunity to kind of understand the day-to-day experiences and to get to Richard's point of some of those questions that we do need to ask in the registry. But as Gitta kind of pointed out, the registry is only as powerful as the data that is in it. And so, I think, if it's a plea or an ask or just an empowerment that, these registries, can really inform and change the way that we understand and the way that we do research. But if the data's not in it, then it becomes much more difficult to work with. So as you get these requests and these asks, or if there's people in your community that you've connected with, to point them to the registry to capture their data and their experience.
Thanks. I was just going to say, are you promoting this with your fellow hepatologists around the world so that it's not just very North America centric?
Yes, so the participation, I should have probably put in a slide about that. There's worldwide participation in the registry, right? It's not only it's not only US data. They're worldwide data. We also have translated versions of the registry, so you can fill it out in Spanish, Italian, and Polish at the moment. So yeah, no, there's definitely an international aspect to that.
Actually, I have a question linked to Sharon's question, and it's mostly for the physicians in the room, but for you, Gitta, as well. Like, how, you physicians, how would you like to be approached in order to have an incentive to go into your pool of patients and tell them about the PFIC registry? Because I tried to reach out to my doctor knowing that he has access to pretty much all the Quebec patients, but I just didn't have traction. So I didn't know how to speak to him to show him the importance of sharing those patients or linking them to the PFIC network and to the registry. So any pointers will be appreciated.
You have a comment on that, Emily? Okay, Emily has a comment. Emily knows the answer. She knows.
I was thinking about sort of what the motivation is for patients in terms of like, how is this going to help me? And I think conveying that clearly can also sometimes help the doctors too. And that's probably something to think about how we say that and what kind of materials we provide, which could be an email or a flyer with a really easy link or QR code to give to people. But we have definitely found in our patient-centered outcomes research that it helps in really specific ways, like understanding from your longitudinal data, who do the IBAT inhibitors help and who do they not help, so that we know who still needs treatment, to target at itching. After you start on those, what are the symptoms that still really bother people? And that helps direct people towards like, what do we still need treatments for? Or even if we have treatments that you can take, what are the other burdens that creates for your family? So the sort of registry collection of data, which feels a little bit non-directed, can really help identify what treatments are helping and who do they help, what things do we still need treatments for, and then how do we measure those things that are important to people. It is, I think, the more we can do to sort of specifically identify for patients and for doctors, and that's a good point I hadn't thought about, kind of what is the point of this in terms of like helping treat people better. It may help with some of that traction. From a doctor's perspective, more specifically, having like a flyer or an email with a link or a QR code that's really easy to pass out can help too.
I'm walking. Gitta, can you remind me about the IRB status for this registry?
Yes, so it's IRB approved. We have an IRB board that's for nonprofit organizations, North Star, and they approved the registry. And that is yearly updated. So right now we submitted these financial burden questions, so get the update on that.
Sort of wanted to maybe provide a path about how you get to your doctor to maybe help with the registry. When you need something done from your doctor's office, who do you talk to? When you need something done for your kid for the doctor's office, do you talk to the doctor? The nurse, 100%, and that's number one. So number one, that's your buddy, that's the one who's going to do it, okay? Number one. Number two, if you're at a place that does have research coordinators, and maybe if your kid was in one of the trials early on, so there may be a research component to it, and that person is still there, that may be a person to connect to. So I think sometimes it is a three-pronged approach to get there. The doctors do want to do it, but so I think it's the intent that's there, but then they get piled on with things. So I would propose that you really do think, yes, it needs to be done, and then work around it with the team.
And I would just, just make another, quick comment. Although this study is IRB approved through the network, it is not approved at each individual site. And so there may be some physicians who, when you say, hey, can you look into your database and look at all the patients and see who has PFIC and give them this flyer, they may say, that's actually research and it's not approved here, and may be uncomfortable with that. So I think, this is where the red tape gets in the way sometimes of a good idea. But just to note that you may have different experiences at different centers with different doctors who feel comfortable participating. Because the act of going into a chart to look and find them and identify them is technically research that is, could be considered research, right? And so the physician may say, that's actually not approved here for me, so I can't do that, just to make that point.
Okay, I saw that N was equal to, I think, 130 or 120. What would be 100% involvement? And I know that's an easy question. But could you give a ballpark, maybe?
Look at the prevalence of PFIC, and then
I don't know the prevalence of PFIC. I've never. Maybe that's not easy.
Well, it's 1 in 50 to 100,000, I think.
Yes.
So,
what is that number when you work it out with population, though? I don't.
Oh,
so this is something that in the back of my mind, I keep thinking, I should go figure this out. And I can't find it like just written out. In the United States, there's this many students, I'm a teacher, sorry. There's this many patients, or in the North America, like that number is not readily accessible to me.
I'm not very good in doing calculations in my head, but I think it would run in the thousands in the US. It will run in the thousands in the US because, now I'm gonna really go very wrong here, but we have like 365 million in the US or something like that. 1 in 100,000. Yeah.
We know it's an estimate, but is there any different database that maybe could give these number of people?
The PFIC docs know better than me. I'm just a stats person.
So we don't know, but the prevalence in sort of Europe and North America is about 1 in 50,000 births. So there should be several thousand patients in the US alone. There are places in the world where it is much more common than 1 in 50,000, and because of the first cousin marriages and things like that. In the Middle East, this is much more common than that. So if it's much more than 1 in 50,000 worldwide, and there's 8 billion people in the world now, so there is a lot of patients out there, most of them undiagnosed. But it's not because we haven't got a database, it's because they haven't even got a diagnosis.
Okay, I think that it is time for lunch.